Hey guys, I just thought I'd run you through about a condition we've seen in the clinic this week, frozen shoulder. It's something that's pretty common and can be pretty frustrating. I guess the most classic example we see is someone with gradual onset shoulder pain. They might have been to their GP and had an ultrasound, and that ultrasound often shows a bit of bursitis and maybe a bit of cuff tendinopathy. But as opposed to normal shoulder pain, these people have sort of not really had a mechanism of injury. The pain is quite severe regardless of what they're doing with the shoulder, and it's typically characterized by a significant amount of nighttime pain. So we tend to find these people come in and say, I'm having trouble lifting my arm, it's painful, I can't sleep, it's waking me up, I can't tuck in my shirt, I can't get a cup of coffee out of the top cupboard. I guess what causes this? Typically, we're not quite sure what the exact mechanism is, but we would call it an autoimmune disorder. So your own body is unfortunately doing this to you. We know it's more common in metabolic diseases, such as women during menopause, diabetics, thyroid disorders. You've had a Dupuytren's contraction before, and it can quite commonly happen after surgery. So we've got a couple of patients at the moment, unfortunately, who shoulders have stiffened up quite significantly after surgery. So I guess, how do we diagnose this? Probably our main criteria for diagnosis is that your active range, so how much you can lift your shoulder, and your passive range, how much, say, I can lift your shoulder for you, are the same. If you've got rotator cuff pain, typically you might struggle to lift it, but if I lay you on the bed, I can lift it for you very easily because the muscles aren't having to work. So I guess with that diagnosis, typically the management we suggest to people is to go back to your GP and get a cortisone injection. Now, this is not an injection into the bursa that you may have had or you may have heard people have in the past. This injection needs to be into the joint. That cortisone will act as a very, very powerful anti-inflammatory to stop the inflammation that is attacking the shoulder capsule, so the sock that encloses the joint. If you inject it into the bursa, you typically don't get much benefit beyond 3 days, whereas the injection into the shoulder joint is far, far more effective. What's a physio's role in all this? Well, I guess if it's really, really cranky and you do a lot of stretching from a physio, it typically makes it more and more cranky. So often the first thing we're getting people to do is stop pissing the shoulder off and take it a little bit easy and trying to refer you back to your GP to get appropriate injections. Once you've had the injection and that has settled that initial inflammatory window, then doing stretches from a physio can be really pragmatic in terms of improving your range, reducing your pain, and restoring your function. So in terms of other things that can happen, you can obviously use some heat or ice to help calm some of the pain, but the injections and then follow-up physio is typically what we would recommend as best practice. So if you've got a stiff shoulder, or you know someone who's got a very, very stiff shoulder and they've been struggling, they may have had 2 or 3 bursal injections, but aren't really getting the relief they want, give us a yell. We're happy to have a look at their shoulder or give them a second opinion and see what sort of management and benefit we can provide. See you guys.